Can I have the first slide, please? Yeah, okay. Yeah, okay, fine. Yeah, good morning, everyone. Thank you, Dr. Vijayakumar, as well as Lily, as well as Professor Dr. A. Ramachandran for his nice introduction. Good to see you all. And we bring greetings from Coimbatore. And we are going to have our Cupid conference on May 9th and 10th, the 12th edition of a National Conference on Diabetes. Welcome to Coimbatore. And I'm just going to give a startup for this. I'm supposed to start on the 1st. Asusa has to leave in an emergency. I mean, she's leaving to Mumbai. I just stayed back and doing the next talk. Actually, just as an introductory talk on these obesity. How does the obesity, a silent multiplier of diseases? And mind you that I've been contacted by Lily for this talk, and the slides are also being given to them. And again, do not take any photographs or videos on this presentation, and don't put it on social media also. And all these talks, the discussion which we are going to have is only based on the guideline indication by the regulator. Any other doubts you have, apart from the off-label indications, kindly discuss one-to-one. Now, coming on to the main, what are the key learnings for the presentation? We are going to just talk about why is obesity gaining recognition as a disease worldwide. Many a time we are thinking obesity, when you just see a patient, people also thought, and the doctors also thought, ஏம்மா ரொம்ப குண்டாக இருக்க சார், எங்கள் ஃபேமிலியில் எல்லாம் குண்டாக இருப்பாங்க. சின்ன வயசுலேருந்தே எல்லாம் எங்கள் வீட்டில் எல்லாருமே சின்ன வயசில் இந்த பையன் குண்டாக இருந்தான், லேடிஸ் குண்டாக இருந்தாங்க. People tend to just say like that, and we have been thinking that, okay, obesity is just an appearance. And many of the, all the mothers of children, they concentrate on mainly whether the child studies or not, but a most common complaint to the pediatrician is, sir, என் பையன் சரியாக சாப்பிட்றதில்ல. So people thought, no, the eating is a very major one, and we have been doing. And so the South India and our part of the country is definitely known for the different types and varieties of foods, and we have developed an interest and different flavors of eating. And the last 2 decades we see, even during the COVID period, if you can just see which industry has grown. Anyone? Most of the restaurants have come, and now you don't even need to walk and go and search over a restaurant. Everything is available 24/7 at your home, thanks to the Swiggy and Zomato, making you more and more nutritious, more and more obese. Okay, and so why is obesity a silent multiplier of disease? How does exactly the adiposity increase the risk of multiple comorbidities like type 2 diabetes, the OSA, hypertension, and osteoarthritis, etc.? Why is it important to treat obesity proactively? Many times people thought whether this obesity need to be treated or not, and people did not accept that obesity was a disease per se. Now we are just going to tell you the facts that why obesity should be considered as a disease. Is it a silent epidemic? Obviously yes. Generally we do not use the term epidemic for the non-communicable diseases. With the advent and the growing, the explosion of the diabetes and the obesity across the globe, now we've been forced to call this as an epidemic. Generally, epidemic is the word. Generally, we call this, the communicable disease. Upon a time, we were children. We used to be taught like cholera, plague. People died of cholera and plague. That was called as an epidemic then. Now, this obesity is a silent epidemic. The data just tells you that it's a global epidemic that has a negative impact on life expectancy. Many a time, when you want to treat a disease, people ask you questions. When a patient develops a myocardial infarction, admitted in ICU, comes to the ward, and the cardiologist tells, you should stop smoking. The next question, patient asks, what is the guarantee that I will live more by stopping smoking? Similarly, and many a time, there were a lot of studies, did not address the life expectancy. I think Steno study was the one study which tried to address the multiple intervention factors that said by modifying the multiple factors, you are able to prolong the life of a person. So here on the other hand, these data tells you that Almost we have 2.5 billion adults overweight and 890 million adults with obesity in the globe. Again, the life expectancy for the people with overweight and obesity is reduced on average by 1 to 2 years with BMI 27.5 to 30, 2 to 4 years with a BMI by 30 to 35, and 8 to 10 years BMI for 40 to 50 years. So people need to be a little more serious on that, and please do that. And when compared with these data, where people with versus people living without obesity also, okay, they try to compare. These are Indian data. We saw about globe. This is in Indian data. You can see almost the data. The Kerala tops almost 65.4%. The Tamil Nadu 57.9%. You can see the 40% of women in India are affected by abdominal obesity, with many exceeding the recommended waist circumference. So just all my friends, just kindly make it a practice. I think we are quite senior, mixed population here. Kindly make it as a practice to do simple measurements like waist to hip ratio. I'm going to tell you. And so obesity is a disease that impacts health today. Obesity is defined as a prevalent, complex, progressive and relapsing chronic disease characterized by excessive body fat, adiposity that can, very important to note that can impair your health. People are coming there only. When it's affect your health only, people are bothered. As long as your appearance, many people are not bothered. Again, the Obesity Medicine Association has defined as a chronic, progressive, relapsing, untreatable, multifactorial neurobehavioral disease wherein an increase in body fat promotes adipose tissue dysfunction. We're talking about the adipose tissue size and numbers. Here the adipose tissue, there's a dysfunctional adipocytes and abnormal fat mass physical forces resulting in adverse metabolic, biomechanical and psychosocial health consequences. And so when you call a particular thing as a disease is defined by one, deviation from the normal or healthy structure or function of a part, organ or system of the body, caused by underlying pathophysiology. When you say it's a disease, there should be underlying pathophysiological mechanisms and should be manifested by characteristic symptoms and signs resulting in pathological consequences that affect health, feeling and functioning. Feeling and functioning, we will talk about later. The obesity has got a multifactorial origin. As I said, genetics is also play. Many people say, in family, ellarume gunda irupanga. That genetics is also a part. We have epigenetic issues, the environmental factors, sociocultural factors, psychological factors and behavioral patterns. So when you treat obesity, all these things factors to be considered, that not only giving medication, not only nutrition, these factors are considered. So obesity is not prioritized as a disease leading to delays in diagnosis or management. But what is the recent change you see? The data suggests that 54% of people with obesity discussed their weight with their health care professional in the last 5 years. 36% were diagnosed with obesity. 21% were offered follow-up appointment correlated to weight after their last scheduled visit, indicating the awareness and acceptance by not only the patients, also by the doctors. So the delay from starting to struggle with the weight to discussing their HCP is a mean of 6 years globally. During this time, obesity-related complications may develop. So we use BMI for a longer time. BMI is no longer the sole diagnostic criterion for obesity. We cannot totally throw away BMI. BMI is there, but BMI has been diagnosed obesity in the past due to its simplicity, reproducibility and general correlation with metabolic and fat mass diseases in population studies. But what are the limitations? The BMI does not account for several factors associated with the risk of cardiometabolic diseases. One, for example, looking at the muscle mass alone may lead to overdiagnosis of athletes and underdiagnosis of people with sarcopenia. Look at ethnicity, different. Many ethnicities have a higher health risk of BMI lower than 30 kilogram meter square, a threshold which was based on studies and predominantly done on Caucasian population. You can look at the adipose tissue distribution. The central adiposity is associated with a higher risk of cardiometabolic disease, and risk and lifestyle factors. The level of physical fitness also can impact the risk of cardiometabolic disease, and the genetic and environmental factors are involved in the development of obesity. So when you address obesity and trying to manage obesity, all these things to be considered. the sex or age also important. BMI thresholds might not be as effective in predicting health outcomes for individuals over the age of 65. Women have higher levels of fat mass than men. ஸோ ஜென்ரலாக விளையாட்டுக்கு சொல்கிற மாதிரி வீட்டில் கொழுப்பு ஜாஸ்தி ஆகிடுற மாதிரி சயின்டிஃபிக்காகவே டேட்டா இருக்குங்க. வீட்டில் லேடிஸ் எல்லாமே தே ஒன்லி ரூல் த வேர்ல்ட் அண்ட் they are stronger today, but the scientific data also show they got more fat. And guidelines are evolving to address the limitation of BMI, and guidelines recommend incorporating additional anthropometric measurements and clinical components in the diagnosis of obesity. The anthropometric components: 1, the waist circumference measures the abdominal obesity, better predicts the risk of mortality, type 2 diabetes and cardiovascular disease than BMI, provides criteria specific to sex and many ethnicities. Then from waist circumference, one step ahead, waist to hip ratio, very simple to do in the clinic, maybe better predictor of cardiovascular disease than BMI. Then the new one is waist to height ratio, better predictor of visceral adipose tissue than waist circumference, waist to hip ratio and BMI, and better predictor of cardiometabolic risk factors than BMI and waist circumference across the sex and various ethnicities. So what do you do about the clinical component? We talked about the anthropometric measurements on the one side. On the other hand, the European Association for the Study of Obesity, the EASO, recommends evaluation of metabolic, functional and psychological status as a component of obesity diagnosis. Not only you measure height, weight, everything. This, the medical, functional and psychological status should be measured. The assessment to include: 1 is medical complications, metabolic risk factors, muscle strength, body composition, depressive symptoms and eating behavior disorders. And the Obesity Canada recommends use of there's a scale called Edmondson Obesity Staging System. You can just simply go through your Google and ChatGPT will give you all these things. The Edmonton Obesity Staging System that assesses metabolic, functional and psychological impacts on the patient with it. Everything will be available in your phone itself. You can look into all these things. And so understanding the updated guidelines to screen and diagnose people with obesity. We have 2 patients here. The patient 1 with a 40-year-old male with a BMI of 34.8 currently has no medical, functional or psychological impairment. On the other hand, patient 2 with a 35-year-old female with the BMI 27.3, WHR of 0.6, diagnosed weight to height ratio of 0.6, diagnosed with depression and hypertension. You can see the anthropometric side, you can see who is at the risk. Okay, the second patient, high risk fat accumulation, the BMI is high. And if you look at the first patient, the BMI 30 plus, and the medical domain, you got the second patient, you got the medical as well as the psychological domain also, you got depression. Okay. But we're looking at these patients, 2 patients have got both obesity but different patients. So what do we understand the link between excess adipose tissue and obesity related comorbidities? In obesity, I already said the adipocyte dysfunction is the key driver of related complication. First, you can see the healthy adipocyte in the first one, and on the next one, this is the healthy adipocyte, and next one, in obesity, the adipocytes not only increase in the size, also in the number. They become dysfunctional, and adipocyte dysfunction contributes to the accumulation of lipids in ectopic and visceral fat deposits. Whenever there is lipid overflow, in the subcutaneous tissue, you can see the one on the ectopic fat, locations like epicardial, pericardial, hepatic, pancreatic, renal sinus and intermuscular spaces. On the other hand, visceral fat accumulation in retroperitoneal, omental and mesenteric area. So what happens? The enlarged and dysfunctional adipocyte can lead to local and systemic inflammation and insulin resistance in the inflammatory cells like macrophages. They produce cytokines like interleukin 6 and TNF-alpha and MCP1, leading to insulin resistance and inflammation. And so there is an increased risk of many complications of people with obesity. Obesity increases the risk of type 2 diabetes 5.2 times, sleep apnea by 5.1 times, hypertension 2 times, and heart failure 1.6 times, and asthma by 1.5%, osteoarthritis 1.7%, CKD 1.6, and obesity related cancers to 1.1 to 7.1. This just data tell you obesity is a multiplier of all these complications. It's a multiplier. We call it, sometimes we call it in simple mathematics, we have what is called, one is called the geometric progression. Something goes like this. So there was a survey in the resource, this is a survey, this is the data from the resource survey, approximately 75% of the people living with obesity had at least one obesity related complication in the resource survey. People with class 3 obesity, there's a BMI of 40, okay, were more likely to report multiple obesity related complication than in lower. So whenever the obesity is higher, the risk of complication associated comorbidity is higher. So excess adipose tissue increase the hyperglycemia through multiple pathways. Looking at the one acting on the adipose tissue, and if you look at the skeletal muscle, it increases the lipid intake, lipid storage, insulin resistance, inflammation and cellular stress, thereby causing decreased glucose disposal in the muscle. On the other hand, by acting at the liver, causes increased fat accumulation, increased triglyceride secretion, insulin resistance, inflammation and cellular stress, causing more outpour of glucose from the liver, the hepatic glucose production. On the other hand, if you look at the pancreas, increased inflammation, increased islet cell damage and impaired insulin secretion all lead to the reduction in the beta cell, leading to hyperglycemia. So increased adipose tissue deposits in key areas can lead to the obstructive sleep apnea, which in turn can contribute. This is a vicious cycle like, okay, if you look at the obesity, the localized increased adiposity, increase the adipose tissue deposit around the neck. Today they are just trying to measure the neck circumference. Also one of the newer measurements in obesity. So increased adipose tissue deposited around the neck and throat narrows the airway, leading to obstruction and leads to reduced lung volume due to an increased mass load of adipose surrounding the rib cage, abdomen and visceral cavity. Again, reduced chemosensitivity, there's increased sympathetic activity, oxidative stress and inflammation can go to OSA, then causes intermittent hypoxia. Again, hormone imbalance like those with OSA have higher levels of leptin, which can lead to leptin resistance. Please learn this new term, leptin resistance, and which will decrease effects of the leptin. So again, looking at the factors, excess adipose tissue is a key driver of hypertension. Various pathways through the sympathetic nervous system overactivation, through the excess adipose tissue, the overactivation of the RAS system, structural and functional changes to the kidneys, leading on to vasoconstriction, sodium reabsorption, and water retention, leading to the hypertension. And so obesity now a very common problem we are talking about all other metabolic, but simple thing everybody see, every practitioner will see in practice. Obesity accelerates osteoarthritis through mechanical stress, inflammation and metabolic changes, increases the skeletal load, altering the mechanics of and gait, and which heightens the joint stress combined with the chronic inflammation and metabolic changes. These factors can contribute to the osteoarthritis pathogenesis. So main features, they can have a chronic low-grade inflammation, promote cartilage degradation, synovial inflammation and fibrosis via the elevated levels by the macrophage recruitment and pro-inflammatory cytokines like chemokines, adipokines and growth factors. So obesity-derived osteoarthritis, you can see the picture, nice picture, and what are the changes happening in the knee joint. All of you know that knee joint is one of the common weight-bearing joint of the body. And so what are we going to be achieved by treating obesity? Already I think Dr. Usha has talked about the direct trial. Okay, so we are today talking about type 2 diabetes prevention as a primary prevention. And even we are, in fact, our Rotary Club, I'm going to take up a president of a Rotary Club in Sunset and July, and we are going to work on a project of pre-diabetes screening, awareness and early intervention in youth. This project I'm just taking it, probably I'm looking at a global grant to do this. Okay, because many a time we treat only the tertiary complications, So type 2 diabetic prevention, if you have a 10% to more than 10% weight loss, type 2 diabetic hyperglycemia response by 10 to 15%, HbA1c continues to decrease at more than 15%, remission of type 2 diabetes is 10 to 15%. Again, hypertension, dyslipidemia and the cardiovascular outcomes if you have 15% and above weight loss. So whatever mechanism you are able to reduce the weight loss, these benefits are going to happen. You can prevent a pre-diabetic person from developing diabetes and reversing to normal glycemia. A newly detected diabetes, put them on these things and reduce the weight. You bring them to pre-diabetes and bring them to normals, and you are going. So in addition, you can address MAFLD, MASH and PCOS also have a definite beneficial effect in terms. People ask, this weight korcha enak enna benefit kedaikum? These are all the benefits you are going to get. These are all not my own data. These are all derived from many studies. So what is important, my dear friends? So many a time we talk only at the numbers. What is the blood pressure? What is your cholesterol and sugar? And we do not ask the patient, how are you? How do you feel? Did you sleep yesterday night? How is your life otherwise? So the idea of any, as far as I am concerned, the idea of any medical treatment should improve the quality of life of the patient. Is very, very important. That is a very, very ultimate aim of the medical treatment has to be. So ask about the quality of life. So if you are able to reduce weight, excess weight can reduce a person's quality of life. If you are able to reduce it, weight reduction is associated with higher quality of life. So in patients with obesity, a decrease in BMI of a little as 1 kg per meter square is associated with higher quality of life care. So whatever treatment you do, any disease, leave alone this obesity, any disease, any treatment, kindly see that it improves do not complicate anybody's life by your treatment. Kindly do not do any harm. Try to improve the quality of life of the patient. I'm just going to end up by saying this summary. Obesity is a complex, chronic, progressive and relapsing disease driven by complex interplay of systems within the body and requires long-term management and treatment. Mind you friends, it is not short-term. Many times people ask you, how long should it take? How long this medicine to be taken? And so many a time this obesity is to be treated lifelong. Number one. So again, in obesity, adipocyte dysfunction is a key driver of related complications. Diagnosing and treating obesity with urgency can prevent or reduce the risk of a spectrum of obesity-related complication and improve the quality of life. Very, very important. We all should live a quality life, whatever be the age. And if you're getting a patient as 80 years also, don't try to do a complicated treatment we should not do. Try to do something to improve the quality of life and with the people with obesity. And I thank you very much.